Minimally invasive surgical therapies, also known as MIST, have significantly changed the treatment landscape to help men suffering from symptoms from an enlarged prostate. Today, I'm very excited to have urologist Dr. Rahul Mehan as our featured guest today on the podcast to get you up to speed with what you need to know about the iTind procedure. So stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On the podcast, we'll be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. We are excited to be partnering with Olympus America today to bring you a very special guest, Dr. Rahul Mehan. He is the founder of East Valley Urology Center in Mesa, Arizona, and a nationally recognized expert in minimally invasive treatments in urology. His practice focuses on offering new technology to provide state-of-the-art urologic care to improve patients' quality of life. He is an expert in minimally invasive surgical therapies for BPH, including the first in the region to perform the iTind procedure. He is continually invited to teach surgery throughout the U.S. and led several workshops at the most recent American Urologic Association national meeting this year in San Antonio. He is also an influencer on social media, and I have enjoyed following his content, which are not only educational, but also very entertaining. Dr. Mehan, welcome to the Prostate Health Podcast.
Thank you for having me. I'm honored to be here.
Well, it's certainly been exciting to see some of the new advances in technology, which are really allowing us to better care for our patients who suffer from symptoms of an enlarged prostate. You continue to embrace the integration of minimally invasive surgical therapies, also known as MIST, in the management of benign prostatic hyperplasia. Today, we will be highlighting a MIST intervention, the iTind procedure. Dr. Mehan, for our listeners, what is the iTind device?
The iTind device is a temporary nitinol implant that reshapes the anatomy of the prostatic urethra, gently creating new channels for urine to flow more freely without burning or cutting. It's interesting. It's actually what we call the first true MIST procedure, in that it is a minimally invasive surgical therapy where nothing is left behind. We put this implant in. It stays in for about 5 to 7 days. It reshapes that prostate in that time, and then we remove it. Kind of really a novel concept in BPH treatments.
Now, I understand that you were the first in Phoenix to perform the iTind procedure. What initially drew you to this technology and to be one of the first urologists to implement iTind in your region?
Oh, for a number of things. I saw this years ago, and we talk about this renaissance that we're having in urology right now. It is truly what I call a prostate renaissance. I came out of training a decade ago, and when I left training, we really didn't have a lot of options other than medications or traditional surgical therapies. And there's nothing in between. And what I like is that this is a procedure similar to other MIST procedures that allows more men to get treated. It really opens the door to guys that were on the fence, that were just scared of traditional treatment. So scared of going to the operating room, scared of having tissue removed, tissue that was burned. Patients were getting nervous about having an implant that was permanent, that was placed in their prostate. There's still a huge need for men to have a better treatment option. And there's data out there that suggests that only 2% of men that have severe symptoms get treated. 98% of guys that are having bothersome symptoms just sit on the sidelines because they're too scared of the traditional options that have been presented. So I saw iTind as a possibility to open new doors to present to men to get treatment that they need. The other thing that's interesting in this prostate renaissance, we've seen patients take a stance. They don't want to go on medications. These medications have side effects, especially sexual side effects. And it's been kind of cool to see this renaissance come out that help men protect that. And this is like we talked about having a true missed procedure. There are no sexual side effects with iTind. So when I saw this, that there's no sexual side effects, this is a non-permanent implant that's placed. You get rapid symptom relief with this. There is a low catheterization rate, and we'll talk about that. The catheterization rate is less than 5%. And a lot of men don't want to have a procedure where they're likely to have a catheter. And it's pretty interesting how we place this. This can be placed in the office or in the operating room with a rigid cystoscope or with a flexible cystoscope. There's less trauma when you put this into somebody. And I saw all these selling points for this technology, and it just really made sense to offer this to my patients in Phoenix.
Well, who would you say then is the ideal candidate for iTind?
It's really indicated for a man over the age of 50 who has bothersome lower urinary tract symptoms from an enlarged prostate. And this may be ideal for patients who are unhappy with medications or who want to come off medications and are not ready for a surgical procedure. These missed procedures may not be a permanent fix, but you're not going to hurt yourself in the future by doing this procedure by any means. I think it's a very safe procedure for men. So yeah, I look at patients, and when they walk into my door, if they're over 50 and they have these symptoms, I definitely work them up. And if they're an appropriate candidate, this is an option that I present.
Now, when counseling patients, what do you discuss in terms of any risks to consider with the procedure?
Yeah, like with any medical procedure, there are risks. And I don't want to downplay those by any means. Implanting the iTind device for that 5 to 7 days can cause pelvic discomfort. You have this nitinol device that's slowly and gently expanding in the urethra, and that can cause some blood in the urine, some pain with urination, some urgency, some frequency. And in rare cases, this can actually cause a urinary tract infection, which can be treated with antibiotics. Also, there can be a rare incidence where when it's implanted, men can't urinate. And again, that's less than 5%, but that is a risk.
Now, how does the iTind differ from some of the other missed interventions currently available?
Yeah, I do all the procedures. So it's interesting. In this renaissance, I came out in 2012, and in 2013, UroLift got released. I was one of the first people to do UroLift. And then Resume came out in 2015. I was one of the first to do Resume. And this came out in 2020. But this is different. Again, you're not leaving a permanent implant. And I do a lot of work in prostate cancer, and I am doing a lot of focal therapy as you are. And what we found is MRI is such a vital tool in diagnosing and in treating men with prostate cancer. I think of it as a mammogram. We really need to have those MRIs to screen men, and it's a much better test than just a PSA. So I do a lot of MRI, and I do a lot of MRI targeted biopsies, and I do a lot of MRI targeted treatment for prostate cancer. And I really do feel it's the future. And with UroLift, you're leaving an implant behind, and it's making it harder to follow men and treat men with prostate cancer in the future. And that's something that I take very serious. So I like this. You're not leaving anything permanent in the patient. It stays in for 5 to 7 days and it's out. With Resume, with some of the steam treatments, there's a lot of inflammation and a lot of changes that go on in the prostate. It's really not a missed procedure. It's more like a resective procedure where you're removing tissue. And that process works extremely well, but there's a period where the patient has to heal, and it can be rough. I tell patients they're going to want to punch me for the first month and then hug me after that. And, it can be kind of a rough ride of having a catheter and whatnot. And not all patients want to do that. When they look at that, that may not be a good option for them. So this offers something different. It's a newer option I can put on the table, and it sits well with a lot of patients when they put all the options together. This is unique. And again, this has 0 sexual side effects. And I think that really drives this option home for most men. There's a sexual survey that came out years ago, and they looked at what are men prioritizing when they select a BPH procedure. And 95% of men prioritize maintaining an erection, and 92% maintaining ejaculatory function. And a lot of the procedures don't do that well. And this one has a 100% chance of preserving ejaculation, that money shot. And we've downplayed that for years as urologists, but patients value that. And this is an option that I know is not going to hurt them. The other thing that's interesting about this technology, it's the only missed procedure that treats the bladder neck out of all of them. And when I'm working up patients, and in that workup, I'm doing an ultrasound and cystoscopy and doing some recon and looking inside. If they have issues with the bladder neck, like a high riding bladder neck, the other missed procedures don't treat that. This is the only one that really does it. And it's kind of like doing a TUIP for urologists, where you're making these grooves and opening that bladder neck. It really helps. When you look at data side by side, how does this compare to UroLift or Resume? You actually have better flow rates when you look at individual FDA trials side by side at 3 years out. This really does an amazing job of helping men pee better, having them have a better flow and reducing their symptoms. It's unique in that. The other thing that I find unique about this procedure is you can do it on men on anticoagulation if you feel it's safe. That's not a contraindication for this procedure, which is unique too. So I have a lot of older men that can't come off a blood thinner and want to have a BPH procedure done. This is a great option for those men. And, I like it.
Now, from a patient perspective, I was going to see if you could walk our listeners through really what they can expect in terms of the procedure.
Yeah, it's typically for me right now, patients are having it done in the operating room. And I've done it in my office. I've done it with patients awake. I've done it with patients asleep. There's all the options are on the table, and I've done it both ways. But right now I'm doing it in the operating room. Just from a reimbursement standpoint, insurance companies are wanting me to do that, and that's fine. The whole procedure takes less than a few minutes just to put that in. It's really easy to place it. I've done a lot of these, so I think I've gotten better at it. I put it in the operating room. They wake up. Again, most patients are catheter-free afterwards. Post-procedure catheterization is very rare in clinical studies, again, less than 5%. In the event that a patient goes into retention after the procedure, I gently place a catheter in for a few days. But again, that's pretty rare. Patients go home, they have a string hanging out of their urethra. That's the retrieval suture, and that's important to keep that in place. That stays there for 5 to 7 days. And patients just go home, no catheter. They can kind of do normal things. I don't have them do anything too strenuous when they go home. They kind of take a week off of no physical activity, no exercising, no sex. I really coached them before not to take in a lot of bladder stimulants. You don't want to drink a lot of caffeine or carbonation. You just want to kind of have a relaxing week with that in place. Some patients have some discomfort with it. It can cause pelvic discomfort. You have this temporary 9-in-all device inside you. And I have patients, I think really finding a soft surface to sit on helps. Not hard chairs, not going for long drives. Using a pillow when you sit or a cushion can make a big difference. In my experience, usually patients have discomfort the most during the first 2 to 3 days. And then that gets better pretty quickly. And by day 5 to 7, when we take it out, they're doing much, much better than they initially do. I typically prescribe a number of medications during the week, and I want patients to take it. They shouldn't have to have discomfort or suffer. We have medications to help with that. And my strategy is to give them more medications than they need. They go home with so much. I send them home with an antibiotic. I send them home with a medication called Pertinent that turns their urine orange, that kind of numbs their urethra. And then ibuprofen and Tylenol. And that's typically enough for most patients. But then I have the silver bullet you can pull out if you really need it. And I send patients home with a narcotic. If you need it, you can take it. And then even above that, I send them home with a steroid. And I use like a prednisone Z-Pack setup where it's just a very small steroid that they can start taking. And that can significantly take down inflammation. In Europe, they routinely put patients on steroids for this procedure, and patients do extremely well with it. So I give patients a ton of medications, and if they need it, they have it. And then it's temporary. Again, like 5 to 7 days, it's out, and they have this rapid improvement right after. So I have them kind of focus on the future and how the benefits of the procedure. So it's interesting for the first 5 to 7 days, but I've never had a patient come back to my office and demand that it had been taken out. They do pretty well during that 5 to 7 days.
Now, I'm sure a lot of men and their loved ones want to know, what does recovery look like after the procedure in terms of, okay, how does the device removal process work? What limitations can they expect after that? And then when to maybe start seeing improvement in their symptoms?
Yeah, great question. So they come back to my office. I remove it in my office. You place a catheter. There's a retrieval suture that's usually taped to their leg. So we use that suture. It's really important that stays in place. And we put a catheter over that. It goes into the urethra. It will help the iTind device collapse, and then it's all removed together. And before I do that, we use a lot of lidocaine jelly to kind of numb everything. I have nitrous in my office, I know as you do, and that can help too for some patients that want to be sedated a little bit. But the whole process takes a minute. You're placing a catheter, pulling it back in it, and taking it out. And then right when it comes out, patients do extremely well. They may have some blood in their urine for a few days. They may have some urgency and frequency just from taking it out, but they notice an improvement right off the bat. When you look at their clinical trials, the most improvement was seen at 4 to 6 weeks. So I tell patients, give it a month after I take it out. We'll see how you do. I usually have them back at 6 weeks, and they're peeing extremely well. I remember the first guy that I treated, he found me from Maine, and I have a lot of presence online and social media and on YouTube. And he saw that I was doing this. Is back when it first came out, when I first launched. And they drove on out from Maine. He had the procedure done, and then he drove back. And he called me when he got back. He's like, dude, this is the first time I've been on a road trip that I didn't have to stop more than every city to pee. And he's like, my wife had to pee more than I did. And hasn't been like that in a decade. I mean, he saw that improvement right off the bat. And that's not the same for every patient. And every patient's experience is different with this technology. But it has this rapid improvement, which is unique with iTind. And another reason why I love it.
Well, thank you for sharing that. I mean, it's so cool to see some of the responses that you get from helping these men out and just to see their quality of life improve. And I think it's very rewarding, but I think patients have been suffering with this for many years. And so to get some relief, it's just really neat to see. So I appreciate you sharing that.
Yeah.
Yeah. Now, I know we have a lot of urologists listening in. Can you share with our colleagues any clinical pearls you've gained from your iTind experience, not only for those of us that are gearing up to begin implementing the procedure in our practice, but also for those that have already started performing iTind and are still maybe early on in their experience?
Yeah, that's a great question. So I think it's important to find the right patient for the right procedure and really screen men well. And I follow AUA guidelines when I work up patients, and all patients get an ultrasound. And I really want to measure the prostate and know what I'm dealing with and perform cystoscopy, make sure there's nothing else going on inside. You're looking for the right patient that is motivated to have this done, that really has those same desires of preserving sexual function, getting off medications, and works best for their lifestyle and their anatomy. Technically, you want to avoid patients that have a median lobe. Some of the contraindications are patient has a median lobe, don't do it. It will get stuck, the iTind device, around the median lobe, and it can make it very hard to remove. And it won't treat the median lobe. It makes grooves, again, 3 different grooves throughout the prostatic urethra on the sides and then 12 o'clock. So they have a median lobe, probably not a good patient. Another contraindication is prostate cancer. You don't use this in patients with prostate cancer or bladder cancer. It's not indicated to be used in a patient with a neurogenic bladder. So excluding those men, I think, are really important. You really want to have the best outcomes with this technology. If you have a guy that just has a really tight bladder neck, maybe this is not the best option for that patient. And you really want patients to understand what it is and go over those risks and benefits in detail before you do it. I would select smaller prostates to start with. This is really indicated up to 75 grams. I've done large prostates with it, and it works extremely well. But when you get started, you probably want a little smaller prostate just so that you can place it more easily. And I would consider doing it in the operating room the first couple so that the patient's completely asleep, that's in proper position, and you feel good about it. There's some nuances when you place it, just how it feels when you pull it back and how that anchoring leaflet goes over the bladder neck and sits in the floor of the prostate. It's a feel that once you do it a couple times, you get it. So the first few times you want to make sure you have the right patient and easy anatomy so that it's placed perfectly.
Well, it's certainly great for urologists to have this minimally invasive tool at their disposal, offering symptom relief, minimal to no downtime, and really with the ability to preserve sexual function. Dr. Mehan, any final thoughts today for our listeners?
Yeah. If you're interested in listening to this, you probably need something done. Go see a urologist. Get worked up. Explore your options. You don't have to suffer. We have technology. This is the Renaissance. I'm like Picasso. Well, let's do it up. Let's fix you. It's awesome. I think missed procedures are a great option for the right patient. And this is something, again, that is so minimally invasive that it's a true missed procedure. You're not leaving any implants behind. You're not cutting. You're not burning tissue. This is a very safe procedure. And if you're worried about having that device in, take some proactive steps. Really plan that 5 to 7 days well, where you're going to take some time off. You're going to be careful in what you eat and drink, that you have proper medications, and if you need them, you can use them. And I think all men can get through that period of 5 to 7 days and see benefit and do it. Don't suffer. We have technology, we have options, and it is life-changing. I promise you that.
Well, we really appreciate you taking time out of your busy schedule today to join us today on the Prostate Health Podcast. You've really delivered up significant value today for our listeners. So thank you so much.
Oh, my pleasure. I love this podcast, and I'm very, again, humbled and grateful to be part of it. Thank you.
Well, thank you so much. Thank you again for listening to the Prostate Health Podcast. For those of you wanting to dive in even deeper, make sure to check out the Prostate Health Academy. which offers comprehensive and easy to navigate lessons that I have prepared for you. There's also an active private community forum, and I am there every day providing support, insight, and answering questions. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Well, that's it for today. We will see you at the next episode.